Okay, good afternoon. I'd like to call to order the Board of Managers meeting. It's 1:02, Thursday, May 14th. We'd like to open with the prayer and Pledge of Allegiance, please.
Good afternoon, everyone.
Good afternoon.
Let us pray. Gracious God, we come together with gratitude and faith, united by our shared commitment to transforming healthcare delivery for the communities we serve. As we begin our work, give us clear minds as we make decisions that honor our mission, vision, and values. Help us to use every resource wisely and faithfully, remembering that each decision we make affects a patient, a family, and a life. We start with you and finish with you. Amen.
Amen.
Please stand with me for the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Okay, thank you. We are on to item number 3, and that's citizens wishing to address the board, and there are no speakers today. So that will take us to item number 4, which is the approval of the minutes, and that is the approval of the Board of Managers meeting from April 9th, 2026. If there's no further discussions, I'd like to entertain a motion. Got a first? We've got a second. Blake, all in favor? Any opposed? Okay. All right. Item number 5 is the board chair report. As you can see, I'm substituting for DT today. He was out regarding a family wedding, so happy to do so today. That being said, I will have a little bit more to report on the finance update, but no further updates from the board chair, so I will pass this to our CEO, Dr. Duncan.
Thank you, Mr. Chair. Thank you, members of the board. So, as we always do, let's get loud.
Let's get loud.
So, I think we all have been very excited about was the new hospital groundbreaking event. I would like to begin by just thanking all of you that were present at this event. It was such a meaningful and memorable event for JPS and for Tarrant County. I think we all agree. There was quite a few people there. The program brought, for those of you that weren't there, the program brought together leaders from across our community, including Mayor Maddie Parker, our judge, Tim O'Hare, other elected officials, community partners, our first responders were there, physicians, a lot of team members, and students who represent the future of healthcare. In total, we had over 2,000 people in attendance, and that is huge for an afternoon groundbreaking ceremony, and it was probably one of the largest ones Tarrant County has ever experienced.
Fantastic.
Some of the highlights include that music was really great. That musician, James Neville, he greeted the attendings with his original music as guests were arriving. He was the very first participant in our Sound Care program, a partnership that helps connect members of Fort Worth's music community with access to healthcare here at JPS. So he was one of our first Sound Care participants. We also partner with Near Southside Business to support local small businesses in our community. And so a lot of the food and the booths that you saw were set up by our Near Southside business, small business owners. We are also incredibly proud of our own Dr. Elliott, I don't know if she's here, whose powerful rendition of the national anthem truly moved the audience in a special presentation of colors by the Tarrant County Sheriff's Office Color Guard. And I understand that Dr. Elliott's also going to be singing the national anthem at the next court. Is it the next court event? Yes, as they celebrate the 250th year of America. So the judge reached out and asked that she also sing there. We heard directly from members of the JPS community, including our own Dr. Brian Webb, who is our chair of orthopedics, and one of our SHINE program fellow and aspiring physicians. We're also proud to showcase the partnerships that support JPS every day. I hope that you saw the helicopter there. That's actually our care flight that brings in our trauma cases or from rural areas, some of the patients who need care. Also, our Fort Worth Fire Department, our EMS was there. Special thanks to you, board members who were there, including our board chair, DT Nguyen. Our chair today, Dustin Austin, was there, and Dorothy, board member Dorothy DeBose, Demetria Bivens, Reverend Emerson was there. Alan, I believe you were also there. Chuck, I believe you were also there, and Blake. So thank you for your attendance there. I'd like to share the groundbreaking video that was shown during that event. We've added a little bit of the recap footage for this video.
Fort Worth is one of the fastest growing cities in the country. That growth isn't going to stop anytime soon. When I hear about the growth of JPS, the new facilities, the new resources they're going to be putting into the community, it shows me that JPS acknowledges the growth. They want to grow with the city. They want to grow with the community, grow with our residents. And regardless of how big Fort Worth may become, they want to stay that facility, that hospital that people look to when they really need help, and be able to provide those services because they're growing with Fort Worth as we expand more and more.
Well, if I go back 37 years ago, JPS was quite a different place than what it is now. We're a single building. Everybody had to come to the hospital to get care. We have continued to grow in all aspects of the hospital district. And so we've constantly been able to expand the outpatient facilities and going along with that, the inpatient facilities.
We are always finding new ways to expand services, trying to find new ways to reach out to our patients.
You know, JPS it's not just a hospital in Fort Worth, it's a hospital that's for Fort Worth.
I think the quality of the care that we've been able to provide over that time has gotten better and better.
With just the constant growth that we've seen here in Fort Worth over the last several years, we've got to have enough space and enough room to care for those patients. But you've got to have that infrastructure built to be able to house these folks as they come in. So with the expansion of the hospital, we're able to do that.
This facility is a healthcare facility that is deemed to serve the county.
As far as I'm concerned, they're the reason why I'm alive today.
The main doctor that took care of me over there told me, go to JPS, you'll get the treatment that you need.
The care team is what I remember the most because they were really there.
They really made me want to get back. I would say that I received excellent care at JPS.
They feel the love here, and I think the people who work here feel that as well.
The new building, the hospital, the build out that we're doing will allow us to be able to reduce the waiting time for a room. It will also allow us to have all of our patient care services on the east side of Main Street, which will really help the efficiency for nursing, physicians, and all. You know, it's kind of like human nature. If it's nice, I feel nice. And that goes with healthcare and anything else.
I'm excited because the two are meeting together. The professional side, medical side, and the community.
It's not just a hospital, it's not just a fire department, it's not just all these little specific things throughout our community. It's all of us coming together in true partnership to make it better for the residents we all serve.
If you thought we were providing great services before, you haven't seen anything yet.
The buildings will be phenomenal. It'll be state-of-the-art. It will be a top-notch medical facility. But the only thing that makes that work are the people that work inside of it. Empathetic people, compassionate, but also courageous people. When you combine those two things, top-notch people with a top-notch facility, it's going to be the best care that anyone in Tarrant County can receive.
I heard Dorothy say she loves that. I do too. Let's see. Yeah. Okay. Thank you. Yeah, it really is quite good. And as Chief Noakes, ex-police chief, stated in there, it's only as good as the people who are inside there. So I think it was very meaningful. So many of you probably heard on the news of a shooting on April 28th, 2026, this year. On that morning, one of the community response unit members, Edward Zabata, of the Fort Worth Police Department's, it's called, Civilian Response Unit, was critically injured while responding to a burglary call in North Fort Worth. While taking a report from a resident, a suspect opened fire, striking Zapata in the face, directly in the eye. Despite sustaining serious injuries, he continued to protect and move the resident to safety until additional officers arrived on the scene. Once first responders arrived, he was immediately transported here to JPS. I just want to remind all of us that for JPS, incidents such as this serve as a powerful reminder of the vital role we play as Tarrant County's longest-serving Level 1 trauma center. Every day, JPS stands ready to provide life-saving care for law enforcement officers and for all community members during their most critical moments. This incident reminds us that our trauma teams, our emergency physicians, our nurses, our surgeons, and our support staff are prepared 24/7 around the clock to respond with expertise, compassion, and urgency, fulfilling our mission to care for the communities we serve when they need us most. I'd like to give special thanks, and I know they're busy in the trauma area, but to members of our care team, which include Dr. Fultz, Dr. Stevenson, Dr. Koska, and Dr. Choi. You can see here as he's exiting, again, the community surrounding, but just want to call attention to the fact that this is the work we do, it's the business that we're in, and this is what's important. Okay, so as always, JPS is always celebrating. I know you guys are probably thinking that. Do we do any patient care at all, or do we just celebrate? But here during Nurses Week, we celebrated our amazing nurses. Our JPS nurses represent the majority of our workforce, and this time allows us to honor and appreciate our dedicated nurses for their countless service and the quality care they provide to our patients. The week was filled with several special evenings, including recognition of our 2026 DFW Great 100 Nurses. I'd like to thank board members again who were present, Blake, Dorothy, Alan, for joining us during the Nurse Awards Celebration event, and to all of you for continuing to support and to recognize the work and contributions of our nurses. To conclude my report, I would like to highlight the work we do at JPS related to patient experience. In April, we celebrated Patient Experience Week, but as a network, we recognize our patients each day as our true north. Dr. Badamosi, if you can come on up here and join me. For JPS, patient experience is foundational to delivering high-quality, equitable, and patient-centered care while fulfilling our mission to transform healthcare delivery for the communities we serve. Patient experience is different than patient satisfaction. Patient experience is a core quality measure that evaluates how patients perceive key aspects of their healthcare journey, such as effective communication with our doctors, our nurses, and our staff, responsiveness, care coordination, and then also comfort and safety. Today, Dr. Badamosi, who many of you have had opportunity to meet and who oversees our quality across the organization and is our Chief Quality Officer, is going to provide an overview of why patient experience is important through the lens of our CMS rating and our leapfrog. For our newer board members, CMS, which is the Centers for Medicare and Medicaid Services, oversees national hospital quality standards and reimbursement, while Leapfrog is a nationally recognized organization focused on hospital safety and quality transparency. These measures increasingly impact not only public trust and reputation, but also quality performance, accountability, and reimbursement, making patient experience a critical component of how we care for our community and measure success as a health system. Dr. Badamosi, thank you for being here today and reviewing where we're at with our quality. And these are national, actually.
Yes, ma'am.
Metrics.
Thank you very much. Good afternoon. Patient experience is quality, and quality is patient experience. As clinician, healthcare worker, we do not get to define alone what quality care is. Our patients are the primary decider of what quality care is. So patient experience is foundational to what we do in JPS. From time to time, quarterly, I bring the internal quality data to the board, and I share with you what we are doing, both patient experience and other metrics that we follow. Today, we are using an external lens. How does the world see JPS? How does our community see JPS? Another level of objectivity, looking at how we are seen. I will be presenting 2 external quality rankings that are foundational to understanding any organization objectively. And you will note throughout my presentation that a whole quarter of the weight of this external quality ranking is patient experience. So if we are not doing patient experience right, we are not doing quality. So patient experience is quality. So as I mentioned, these external quality ratings are really, they translate all of our broad hospital data into something that is really simple, recognizable for the public to understand in our community. They shape the choice of patient, especially now that we have AI tools everywhere. They can really figure out which is the best hospital in my area. They will pull on resources such as this. 2 matters most, the leapfrog safety grade and the CMS star rating. And of course, the standards are changing. It is no longer sufficient in the world of quality to improve over self. It's now how well are you improving compared to how well others are improving. So that is the new standard. And this, both the leapfrog safety grade and CMS star rating, and including other programs such as the hospital value-based purchasing program, have incorporated that methodology into their rating system. So JPS today, we are leapfrog safety grade B and CMS 4-star rating. Why does this matter? And where are we going with this? CMS hospital star, quite often you will hear about health grades, you will hear about US News World Report, you will hear about all different quality rating. They all pull their data from CMS hospital star rating because they have the most comprehensive objective data available. They just add 1 or 2 other methodologies, but the backbone of any quality ranking system, the most comprehensive is CMS star rating. So if a CMS star rating goes for any organization, so do external quality measures go. Our current CMS star rating is where 4. And this has been a journey over the past several years, and we have made significant strides and improvement in being a 4-star hospital. The maximum is 5-star hospital. So this is something that we have worked at over the last few years to get to this point. What is the methodology and how do we understand CMS star rating? As I mentioned, they use 52 measures to look at us from an external, and they compare us to other organizations. They divide it into 5 domains. You can see there is mortality, death rates for selected conditions of patients that come to our hospital, safety of care, readmission, patient experience. You can see about a quarter of the weight of this program is patient experience. Then, of course, timely and effective care. Safety of care, I'm highlighting there because it even carries an additional weight that I will emphasize in subsequent slide. So there is now a safety ceiling with a CMS star rating. In all of the 5 domains I shared with you earlier, safety is now a constraint. If we do not perform well in safety and we're excellent in all of the other domains, we will be penalized, which means if we're in the bottom 25% of hospitals across the nation in terms of our safety score, we cannot go beyond 4 stars. And from 2027, they will actually deduct a star, regardless of where you fall. So safety is no longer just a domain, it's a constraint. And basically, safety means, do our patient, when they come to our hospital, Do we treat what brought them to the hospital, and how well do we prevent harm from them really acquiring any other diagnosis that they did not come in with? So that is safety. How well are we doing that becomes very important. And that ties in directly into patient experience, because we do not want to give our patient a diagnosis they did not come into the hospital with. So as I said, how do we compare in terms of our performance with other safety net hospital and regional peers? JPS network is up there. We have Parkland Harris in Houston, as well as Cook in Chicago and Grady in Atlanta. We are doing very well amongst the safety net hospital. Even amongst our regional peers like Baylor All Saints, we are 4 stars as well as they are. So why does star rating matter? It's the most visible quality signal. This is the derivative. This is what patients see when they really want to understand a hospital. And this is how payers also see the organization. Some of the measures that all payers, third-party payers look at is how they see. But more importantly, is about the investment of this community into the hospital. This is another evidence that the investment being made into this hospital by the community is actually producing measurable quality gains for us. So that is all I have for CMS star rating. The next program I'll be presenting will be the Leapfrog safety grade. This shifts the lens a little bit. They focus mainly on safety and patient experience again. They do not look at other mortals. So we are safety B. This is an improvement from prior. We were safety C, and this is a good trajectory again for JPS. This is the methodology of Leapfrog. They look at safety, diagnosis that patient did not come in with, events or situations that they acquire while in the care, while in our care. They look at infections acquired in the hospital, post-surgery problems. What is our practice like to proactively prevent errors or these safety events from happening, and other safety problems such as falls, pressure ulcers. And of course, how do the doctors, nurses, and staff treat the patient? What is the patient's perception of their care? Is very heavily weighted with the Leapfrog methodology as well. Our strength, we do have a lot of them, and I just really have to put there our computerized order entry system. That investment is paying off significantly in really reducing errors proactively. Patient experience is a huge focus across the organization. As I stated at the beginning of my presentation, we do not get to define quality. Our patient define quality in this organization. And every year in the summer, we do a culture of safety survey. What do the people, the staff, us, the physician, the nurses, everybody that works at JPS has to weigh in on what they think about our safety, and we do bring that report back to the board. And over the last 3 years, the engagement of the staff, what they think about safety in JPS has been significantly improving. And there's really a strong evidence that says how the staff that work in a hospital feel about a hospital directly correlates to patient outcome. Priority improvement areas, where are we focusing on? Hospital-acquired conditions and infection. We really are focusing on those. We just don't want to control those. We want to prevent it, right? We do have a daily safety bundle. We have to be proactive. If we do not have any plan in place or any process or structure in place, they will happen. So we really have to assume that they will happen if we don't do anything. And that has been our strategy, and we're beginning to see that pay off. In terms of our Leapfrog grade, how do we compare with other safety net hospital and regional peers? Again, we are really doing well compared to other hospitals and our regional peers. But again, we know it's a letter grade A to F. We are B, and we know we still have a lot of work to do. Why does the safety grade matters? It's really the same thing. Patients choose hospitals they trust. Top of mind for any patient coming into the hospital is safety. Are they going to treat me well? Will I develop any complication? Will they figure out what is wrong with me? And so that is very important. When our patients don't feel safe, nothing else matters. So safety is really an important focus of what we do. The key thing, and I think this is the tone and expectation that Dr. Duncan has asked us. I remember the first time I walked into our office, the first thing I heard was, no quick fixes. We will do this the real way. Any solution we are putting together for either quality or patient safety has to be long-standing and has to be hardwired. And the second principle is all of this external recognition, as much as they are, really should be a side effect of the work that we do. They are not the main focus. We know what our internal data is. We know what our external data is. The key is to work on those. And we believe if we focus on that and we do a good job of that and our patient actually feel it, as well as our community, all of these other ratings will fall into place naturally. So that remains our process. That's why we're still maintaining patient experience. They are our best teacher. They provide us with the best feedback. Every improvement that we are developing, we're hardwiring. Every patient, every day, especially when it comes to safety. We really want to ensure that proactively, are we looking at patient from head to toe to make sure that there's no skin breakdown? Yes, every day, every doctor, every nurse will have to review that in an auditable and trackable way. That is our approach to patient safety. The other issue is hybrid EHR measure. This is actually something we are excited about because, again, moving forward, CMS is adopting this as a measure. Not only would they look at what is our percent readmission, they will look at how sick were this patient when they came into you. Because we know at JPS we take care of the sickest patient. Dr. Kirby is here, the ER is always full. They will now start considering other structural and patient-specific factor in looking at quality metrics. So we are looking at that as well, making sure that we actually get a quick picture of what is going on with our patient when they present under our care. I mentioned daily safety bundle. This is on every patient every day. It looks at falls, restraints, skin, catheters, anything that can cause harm to the patient. Every patient every day to be reviewed by the team taking care of the patient. Proactive tool for catheter infection. We are assuming it's going to happen if we put in a catheter in a patient, if we don't do something about it to make sure it doesn't happen. We're assuming patients are going to fall if we don't prevent it. One of the areas that we are doing a lot of work is in post-surgical safety. These are vulnerable. They come here, they have their surgery, everything goes great. We do know that the likelihood that a patient will develop a complication after surgery is primarily a patient factor, but the likelihood that they're going to suffer harm is dependent on us. Are we recognizing it early, and is our process strong enough to actually prevent that complication from being established and they suffering any lasting consequence? So that's our approach to post-surgical safety, and we often refer to that as the PSI 90. Thank you very much. I will take any questions.
Where do you see your biggest opportunity for risk and exposures? Is it by department? Is it by time, day? Where is the biggest exposure in that safety?
Our biggest exposure in terms of safety arena is volume. From my perspective, we are very busy. Our ED is very busy. We went from the number 13 busiest ED to number 5 within a year. So with volume comes, and it demands that we really manage our throughput actively. If we have a lot of patients coming in, those friction points get accentuated. And we really have to become very much involved and hands-on and really intensify our safety protocols.
So you have like a capacity model based on a head count. You get a certain ceiling, pull the lever, or mitigate that risk.
On the back end of things, there's a lot of work that goes on that really helps us. It's color-coded. Are we red? Are we yellow? Are we green? With each of those categories demanding different intervention by a multidisciplinary throughput team that really everybody, all of the leaders across the hospital, our CMO, CNO, COO, everybody is involved in that every day, and all of the departmental heads. So there's real-time situational awareness of where we are in terms of surges in our ED, which is now a very common event, and we are seeing that translate into inpatient as well. From quality and patient safety, it really means our system needs to be stronger, and our processes really has to be strong to ensure that it is done on every patient every day. If we don't do something to prevent it, then something will go wrong. So,
Are these ratings, are they considering volume and capacity?
no.
That's not fair.
Yes. No.
Dr. Badamosi, I have one question, but first, let me thank you for this report, and these ratings are exceptional.
Thank you.
Thank you, Dr. Badamosi.
And I don't think it's a coincidence that they've gone up while you've been in this position as head of safety and quality for JPS. And so everyone in Tarrant County is fortunate that you're overseeing all the safety here. You're doing an exceptional job.
Thank you.
Thank you for that. I had one question. How was our CMS safety score? Do you recall what the number was?
Our CMS safety score actually significantly improved, and that is really one of the reasons why we got pushed up in the star rating, because if you recall in my presentation, it's about a fifth of the whole score is really safety. So, and what do they look? They look at the rate of catheter infection, both the big IVs, the central lines that we use, and the Foley catheters that we use, as well as post-surgical infection and surgical site infection. Those are really the core metrics that they look at, and we actually went up in those metrics, and that really did contribute into pushing our scores up.
Is there like a composite score for safety, or several scores?
There are several scores under the safety domain that looks at different aspects of safety across the organization.
And you talked about the bottom quartile, your capped at 4 stars. Do you know what quartile we were in?
So the way they look at it is different from each of those, and they look at an overall aggregate as well. So we are actually above the bottom quartile now. In years past we were, but we have moved up significantly to above the bottom quartile. And we really want to stay clear of that and really move ahead. As I said, the best tool that we have, thanks to this board, is Vizient, that you all approved that we could have. Because prior to now, we know our internal achievement, but we've never been able to compare it to other people. We do not know as near real time as possible what other organizations are achieving. So if we set a target, and if we're working towards a target, the achievement target for that metric would have already moved. So now we do have some visibility as real time as possible into how other organizations are doing, and where do we need to set our own targets for all of this, not just safety, even from patient experience and even mortality domain. So that's really helped our thinking and our process, and I think we're just starting with Vizient, but I think over the next several months, once we incorporate all of those data into establishing our targets, I think that will really help tremendously.
So Vizient's providing data?
Vizient provides data from more than 1,200 hospitals across the country that also share their data with Vizient. So we do see that. It's not real time, but it's the best we can get to see how they are doing. Otherwise, we'll find out at the end of the year. We may have improved by 10%, but if other hospitals improve by 20%, we're in the bottom quartile. So it doesn't matter that we improve. So we really needed to be an awareness of how other organizations are doing. So this is really, we are so grateful that the board gave us that tool that gives us some visibility into how other organizations are performing.
You mentioned employee safety as well?
Yes, employees. Yes, sir. Pardon me?
Great job. You get 5 stars, incredible. I mean, that's a ton of people. It would be good to see the benchmark of how much volume the balance point of the process through against the others, because it clearly defines how well you're doing. But from a safety standpoint of the employee aspect, you have a severity or frequency ratio that shows, one, what is the skill of the injuries or accidents happening in work, and how long are we off for before we go back?
So that speaks to workplace violence and employee health. We do have a workplace violence program that is really robust, that look at all of those, not just patient to patient, but patient to staff, and exceedingly rarely between staff, which never happens. So We look at that, we classify those. Those have various investigation pathways, and they do report through enterprise risk, and we collect the data, and we share those as well. We also do collect employee health reason. Needle sticks injury, for example, that would be one, or if any employee has suffered any injury or harm in the course of their work. We do have employee health program, and we collect all of those data, review with the senior executive leadership, and share those data with the board as well.
Are we falling under OSHA requirements? Do we have an EMR rating for our employees?
I'm not sure.
So Daphne, you may want to speak to that, but
Not
we're not,
subject to OSHA.
we're not subject.
But we do.
Yeah, we
but
do.
We do follow a lot of those.
Yeah.
We do.
Any other questions? If not, thank you so much, Blake, for recognizing the value that Dr. Batamosi brings to the leadership over quality. And I know, Ron, you have a real interest in process improvement, continuous improvement, and that's where this really goes on, so that everyone is, doing the same thing the same way, hardwiring that through so that we would have positive outcomes that David often challenged us with, measuring at the end of the day how well are you impacting the outcomes of the community. Could not do it without your leadership. Congratulations to the great work that has been done with your team, and to all the clinical team and team members that just do amazing work. So thank you so much, Dr. Batamosi.
Dr. Duncan, you set the direction. You demand this of us, and the team also.
You're the only one that does actually what I asked. No, just kidding.
The CMO, the CNO, the COO, extremely supportive. Couldn't do it.
We could not, no, but thank you.
Thank you, Dr. Batamosi, as well. So,
And that's all, Mr. Chairman, that I
I
have.
think it speaks volume of these ratings, so we appreciate everything.
Thank you.
Thank you. Okay, let's see here. Thank you, Dr. Duncan, for that CEO report. So we are on to item number 7, and this is going to be from Dr. Kirby. This is a request to approve the medical staff appointments and privileges. Okay, with that, we'd like to take a motion. Am I first?
Second.
Go second. All in favor? Any opposed? Okay, thank you, Dr. Kirby. All right, next item is going to be the committee reports and action, and I will start with the Finance Planning and Investment Committee meeting that was held on April 23rd, 2026. For starters, our rating with the agencies, with Fitch and S&P, we're both AA and stable. KBRA at AAA stable is expected to be final by the end of the month, so all the ratings coming out very favorable to the income. I just want to recognize that I'm describing March, even though we're in May, but as of March, the net income was $9.4 million, which fell $2.1 million below the budget. The primary driver to that was what I would consider a paper loss. It was a $6.5 million write-down on some investments that we will recapture, hopefully in the near future. But that being said, it was a $2.1 million budget loss, but our year-to-date income is at $89 million, which is exceeding budget by $24 million. So we're nearly 40% over budget. And like I said, that $6.5 million investment situation, we should recoup that with time as these investments, short-term investments, CDs, et cetera, mature. So that was the primary driver. Beyond that, the performance drivers, there was acute inpatient volumes that were below plan with fewer discharges and surgeries than budgeted. Try not to be repetitive here. The revenue exceeded budget, largely driven by strong revenue yield that continued gains from improved revenue cycle and CHIRP, and operations were favorable to budget, reflecting a continued workforce optimization and cost control. As far as our performance ratios, that was measured in 12 different metrics. All met or exceeded our metrics except for 3. The primary was our AR and our length of stay. I think we spent quite a bit of time discussing that, and we'll continue to monitor that. On to the master facility plan and cash flow. So discussed heavily in finance, and we're at a $2.5 million budget for the master facility plan. I do want to make note that we've committed $949 million to this, but we've only actually spent $310 million. So we're at 2.5 less the 310. It's going to leave us of a total of $2.1 billion, of which we have restricted cash and bond monies of approximately $1.5 billion. So everything's moving along. We did have the great groundbreaking ceremony for the hospital. All is positive. But that being said, certainly want to continue to monitor master facility plan and cash in the future. And I say this and I mention this because, I mean, the simple math is that we're going to need cash as we continue this project. So I just want to make sure that, you know, everyone is having these conversations with the commissioners, because it's a pretty good haul ahead of us here. So, but all positive. Appreciate everyone that did attend that groundbreaking. The committee did approve the 2026, March 2026 unaudited financials. So that was approved, and then we had 14 contracts, 13 were approved. You'll see today, 1 was tabled. The tabled item was regarding outsourcing for the help desk as needed. So I know that there was some more discussion to be had on that. We covered the master facility plans. So I will say there's a lot that goes on at this committee, and would welcome anyone at any time to these meetings, because there's a lot of conversations that go in depth. I know Chuck's not on that committee, but he attended that and he could attest. So all is well for Finance, Planning, Investment Committee. I appreciate it. And I'm going to pass to item B, which is going to be Ms. Dorothy for an update on Quality Patient Safety Committee, please.
It's just not fair that I have to do this report after Dr. Burroughs have given his great report.
Right.
But I'm gonna give it a try. At our April 23rd meeting, the Quality and Patient Safety Committee reviewed system-wide quality performance, key clinical initiative, and patient experience outcome. All of our meetings opened with a patient story, and this one we were recognizing Doctors Week, which said, "Why I love my doctor." They highlighted the experience of a long-term patient who credited coordination, respect, and attentive care with enabling him to maintain independence despite clinical significant health challenges. I will tell all the board members, if you really want to get a feel and see what's going on, attend Quality, because we have in-depth discussions. We learn a lot about what they are doing and how they are measuring it. And just what you received on the presentation today, we get that at that meeting. So I'll continue. The committee received an update on JPS network quality dashboards, which track 34 metrics across 7 domains. Performance was reviewed through the strategic quality composite, a core component of the system scorecard. Measures include the NTSV, cesarean birth rate, unplanned 30-day readmission, PSI 90, and hypertension control. Progress today and targeted action plans as to further improve outcomes were discussed. Additional updates were provided on key operational and clinical initiatives, including community health, supply chains, antimicrobial stewardship, hospitalist service, nutritional services, and the neonatal ICU. These efforts reflect a coordinated system-wide approach to improving care delivery and patient outcome. The committee also reviewed the changes from the Joint Commission, which has expanded the scope of event classification as sentinel events. Leadership emphasized continual transparency with the board and reinforce the organization's focus on prevention and patient safety. Patient experience remained a strategic priority with leadership reporting positive results from net-wide improvement action plans. Year-to-date performance in the alternate participating hospital reimbursement for improving quality award program is exceeding the established target, indicating strong performance against quality-based incentive. The committee approved the neonatal ICU quality assurance and performance improvement plan, which is on the board agenda under consent today. That concludes my report.
Okay, thank you, Dorothy, for chairing that, and I appreciate that update. Okay, on to item number 9. We have got an update not requiring board actions, but item A is to update on neonatal program. Dr. Carson Henderson, please.
Hi, Dr. Carson Henderson. How are you?
Thank you.
You want to go ahead and introduce yourself to the new board members?
Sure. Well, good afternoon. My name is Dr. Stephanie Carson Henderson, and I'm the chair of the Division of Women and Infants here at JPS. And I do have a slide deck. I don't know if that will be.
Do you have the?
Okay. Okay. So in preparation for our upcoming neonatal ICU survey that we have scheduled this fall, I'm here to present a broad overview of our neonatal plan that guides the care that we provide truly our smallest and most vulnerable patients here at JPS. And the full plan is in your packet. So since we do have some new board members, I will just provide some background on the NICU survey process. So the state of Texas has established a tiered system of neonatal care designations that ensure that all infants and newborns receive the appropriate medical attention based on their healthcare needs. There's a tiered system which allows for better allocation and improved health outcomes for newborns across the state. And a facility is assigned a specific level of care designation when it documents both the capability and a history of providing that quality care to the populations described. So JPS has been designated a Level 3 facility since 2018. So what does Level 3 mean for us? It's comprehensive neonatal care that's provided for ill and immature infants as young as 22 weeks gestation all the way through post-term. Now, a due date means that you got to 40 weeks of pregnancy, so a 22-week newborn made it just over half the length of the pregnancy, and that baby can weigh less than the water bottles that are in front of you here. So really critical care that we're providing. Our NICU is licensed for 55 beds. Our average daily census is about 22. We've hit a maximum in the high 40s. In FY25, our NICU admissions were 651. And we're very thankful that JPS has made continual investments here in our program. Very recently, we have 2 shuttles on board here in the hospital. What that means is for our newest and youngest babies, the 22, 23, 24 weekers, every time you move them, there's a risk of complication because they are so delicate with their thin skin, their thin bones. So these shuttles allow us to go from delivery to their bed. They don't have to move again. The shuttle actually provides that transportation from labor and delivery into the NICU area, which is phenomenal. In addition, we do also have 2 jet ventilators on their way, and those jet ventilators are intended to reduce lung injuries, and so we're very happy to have those as well. So the backbone of the neonatal plan is the quality assurance and performance improvement. It's very robust, as you can imagine. Starting at the bottom of the slide here, we have our committees and we have our task force that look at every case review for patients that come in. They are also looking at literature and research to see where the current evidence is, and they're in charge of proposing policy changes or new policy changes for patient care. They then present to that next level, which is the NICU quality team. This is comprised of providers, of physicians, nursing staff. We have physical therapy in there, along with case management, and they determine which of these recommendations need to be advanced. In the middle, you then have the Neonatal Oversight Committee. This is NICU leadership paired with hospital leadership. And this is the committee level that is ultimately responsible for ensuring that that standard of care is provided.
Back to your first slide, Dr. Wilbur, on those two there, you guys trained this year to 26. That's up, you almost doubled it to 603, I think, that previous slide, so it's two today. And the children at 22 weeks of age.
The daily census?
Yeah, how y'all trained this year?
It's actually about the same, very similar to that. We'll have high days where we'll have approaching 30 to 40 newborns in the NICU. Our low days can be in the teens.
We do about how many deliveries?
About 4,000.
Yeah, so most of those deliveries go to the newborn nursery, and then the more critical go up to ICU.
Okay. Part of the survey that we have to do is the outreach and the education to lower level facilities as well. And this is really a moment of pride for our program. This is just a snapshot of some of the organizations that we're providing that education and outreach for. Just last week, the team actually went out and they presented education to 96 new EMS and first responder recruits. So they were showing them and teaching how do you do a delivery out in the field if you're called to that. How do you resuscitate a newborn baby? How do you transport them safely in an ambulance? Clearly that bed and the size of a newborn don't match. And when you look at that bottom picture there, that actually came from our QAPI program. They identified that when there are deliveries outside of the hospital, babies were arriving very cold, sometimes to the point of hypothermia, because they're not yet prepared to regulate their own temperature. Those are really basic gel packs that are similar to those hand warmers that we use at outdoor football games. But they discovered through the research that if they put the baby on the gel pack and transport that way, babies are coming in at the appropriate temperature and they're not at risk for all of those complications of hypothermia. So really phenomenal work that this group does on a very regular basis on their outreach. Okay. And so Dr. Duncan also asked me to give just a very brief overview of another construction project, and that is the new Health Center for Women that is almost completed. We're expecting it to be completed at the end of December here. And this is really for the future of women's health, which is where all of these newborns come from. We know that the need is growing here in Tarrant County as women's health needs are becoming more complex across the lifespan. We know that mental health and maternal health outcomes are trending in the wrong direction. We know that cancer rates are rising, and just as an example of that, in the last 12 months, we've delivered 4 moms that have either active or a history of breast cancer. I've never seen these numbers before. And we know that there's a need for access to timely and coordinated care. So we have an opportunity as this demand continues to grow with this increasingly complex and coordinated care that is needed. There's an opportunity for us to really bring all of these services together to improve access, experience, and outcomes. And so if you haven't seen this, this is a rendering of our new health center for women. This will actually be located on the first floor of the garage that is already completed. It's a warm and welcoming place for women of JPS to come and receive their care. And it's really intended to bring all of these services together in a dedicated facility. It's going to provide and prioritize privacy, comfort, and dignity. It'll again bring that coordinated care together. There will be dedicated spaces for centering pregnancy. And it'll also be an opportunity for us to advance education, training, and innovation in women's health. We have residency programs in obstetrics and gynecology. We have medical students coming through, and we really want to ensure that they're seeing what that future of women's health care should look like when they're done with their training.
Would you just give a very short description of the centering program? Because it is unique to us.
Yes, absolutely. So the standard prenatal care is you go in for a short visit, you have your vitals done, all of the care done, and then you're on your way, similar to the way we see any physician. Centering care is a group model for pregnancy in which you're paired with other moms that are delivering at the same time as you are. So they're typically there for anywhere from an hour to an hour and a half. Not only do they get their medical attention that they need, but they are also provided with education. Every month, there is a new topic in which they are discussing breastfeeding, discussing pain management, and they're there with cohorts of other moms. So maybe you're embarrassed to ask the question, the mom next to you will ask the question. But it really provides that sense of community for the moms to receive additional education. And this has really been proven to improve the outcomes of moms in terms of improved breastfeeding rates, lower C-section rates, lower rates of postpartum depression as well. And so we are one of the very few facilities in DFW that provide this model of care. So at a glance, you've probably seen the new parking lot there on the corner of Magnolia and Main. This is really intended to provide care across every stage of a woman's life with whole person care. There will also be advanced and specialty care with high-risk pregnancy and surgical services. We are taking care of the complex and chronic conditions that include gynecologic oncology, pelvic health, and other specialty care. And we're truly providing that lifelong spectrum. From adolescence, we have pediatric and adolescent gynecology clinics going through those reproductive years into midlife and beyond.
Dr. Henderson, with this new facility, are we going to be adding any services that require us to add some new doctors to our staff?
If I could ask for all the new doctors I would like, I would absolutely do that. Really, our biggest focus is the coordination of care. So we do have those services available, but can we bring behavioral health in? Can we bring cardiac care for women in midlife and beyond? Along with coordinating with our maternal fetal medicine that will be housed there in a state-of-the-art center with their ultrasound.
Dynamic shift from men to women, not just isolated test, but across the continental U.S. And what is the slide shows the increase in cancer towards all hopes of reasons. Is there a trend that's going on or something? I'm thinking family reasons. What's driving the change? What's the number one driver of it?
You know, I think that there is actually an increase across the board. It's not exclusive to women. That's obviously what we see on a regular basis. But we know that cancer rates are not only rising, but they are actually happening at younger ages. And that's across the genders, not just exclusive to women. All right, and these are really our goals with this new facility. Number one is earlier access to care so that those problems can be identified and addressed appropriately. Again, we want better coordination across providers. You can imagine when someone has active breast cancer, that is a lot of specialists involved in that care. We ultimately want to improve our maternal and mental health outcomes across the region. And we'd also like to reduce that reliance on emergency services. We love Dr. Kirby and her team, but we know that they are so busy because patients just aren't getting the care outside of those emergency services. And so this is our future. It's together. It's what we need to do, really, to improve the outcomes of mothers, of babies, which improves the health of communities and families across the board. So thank you for your time, and we'll circle back to the neonatal plan that I believe is presented in front of you to approve as we move to our survey.
So thank you, Dr. Carson Henderson. Yeah, great report, and appreciate your leadership.
Thank you.
Yes, thank you as well. Okay, so then that takes us on to item number 10, which considers matters requiring board actions and/or approval, is item A, is to consider approval of the Level 3 Neonatal Program Plan Resolution, Dr. Carson Henderson.
It is in your board packet, and so she just teed that up.
Okay, I'm sorry.
She just teed.
No, that's
My
fine.
apologies.
She has no additional, she has no
So,
additional.
so with that, I'd like to entertain a motion.
Move approval.
Got my first. Got a second. All in favor? Okay. Any opposed? All right. Thank you. I believe Ron Clevenger. Sorry. Okay. All right. Thank y'all. So, and thank you, Dr. Carson Henderson, for those updates. With that, let's see here. We are on to the consent agenda items. And was there any discussion, or that is, that will require board approval? So I didn't know if there was any discussions or concerns. I know, Blake, we had discussed an item on there, so looking for a motion.
Yeah, Mr. Chair, I'd like to remove two items so we can discuss them a little in more detail, and that's item E, which is the VMware infrastructure contract, and item K, which is the Morris and Dixon pharmaceutical.
Do we have any direction on that, or how you would like to proceed? Okay, I'm sorry,
Here to
Kim.
answer
Okay.
questions about those.
Right.
All right. Do you want me to proceed, Mr. Chairman?
Yes, please.
Okay. All right. We'll talk about item E. That is the VMware license agreement. VMware houses about 1,100 virtual servers for us. And they were purchased by Broadcom in the past year or so. And our contract escalated from about $640,000 a year to $1.6 million a year.
What was the format for it?
641 to 1.2.
You said 1,100 virtual servers?
Yes. We did not find out about the price change until February, which gave us no time to do a lift and shift and do an RFP for a new provider. So we negotiated a new agreement with Broadcom that has a 30-day out. And we are in the process of issuing an RFP for VM services. We'll be looking at Hyper-V, which is one solution, but we'll be doing an RFP for virtual servers. That's what this contract is. It's a 5-year, but it has a 30-day out.
What was your expectation that, how long will we be under this agreement?
It will depend on the responses to the RFP and how long it will take to move those, the current virtual servers. I would hope no more than 6 months.
Okay, good. All right, that's all that I have about that. If anyone else has questions about it.
Any penalty on that 30-day out?
No.
Okay.
No cost.
What was your, any penalty, that 30-day out? Really, you said 30 days, is there a penalty?
Right.
Financial.
No, not in this case. We were very specific, and thank you to Daphne's team for helping us with that.
Any chance of a significant increase in server numbers that we need over the next year?
Significant, no. not at this point, because we're doing a lot of migration to the cloud. Epic is our largest application, and we are in the process of migrating that on June 7th to the cloud, which is good because the servers for that one are about ready to die at the end of the year. We're moving as much as we can to the cloud.
Any other, or discuss K? And then on item K, the contract with Morrison-Dixon for pharmaceutical products, my questions were, when does that 5-year term start? Are we halfway through it? And why do we have a 40%, really a 60% increase in what was originally agreed to for that contract? What caused the change in utilization, cost? Those are my questions.
Absolutely. So Morrison-Dixon is our pharmacy wholesaler for pharmaceutical products. And when we first came to the board, we had approval for 3-year spend, even though it had 2 one-year renewals on the contract. These contracts are volume related, so they could easily go over what we got approved by the board, and the original amount approved was only for 3 years. So we are extending this, the 2 more years that is allowed, but in the meantime, we're going to be also looking at going out for RFP to consider our options around wholesalers, just because it's the right thing to do every 5 years, to look at your wholesaler agreements. And so that's what we would be doing. We do have an out in this agreement. So
is the additional cost for 2 more years, basically, is it 99 million to go for years 4 and 5? Or is that,
right.
What was already budgeted for the 3 years?
It's another 99 million in addition to the 252 that the total cost is 252, the board approved 143.
Well, 143 for 3 years?
Yes.
Okay, so this is just buying 2 more years?
Correct.
So it's not necessarily a utilization, it's an extension of time?
Correct.
Okay. All right, those are my only questions.
Okay, if no further questions, I'd like to entertain a motion.
Yeah, is the motion for the whole?
For the whole
Yeah.
consent
For-
agenda.
for all of it.
Back on this.
Yeah.
Correct, including quality, yes. Okay, I've got my first. Got a second, all in favor? Any opposed? Okay, that motion carries. Appreciate that. We have got no closed session today, so with that, it was a quick one, and our meeting is adjourned at 2:10. Thank you all.